afternoon, ladies and gentlemen, and thank you for waiting. Welcome to Strategies for Improving Blood Pressure Control. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Kim Bolden. Ms. Bolden, the floor is yours.
Thank you, Ryan. As Ryan mentioned, I'm Kim Bolden, Improvement Consultant with VHQC. Pictured along with me is my colleague, Terry Lindsay, who works on the Cardiac Improvement Initiative with me. On behalf of VHQC, I want to welcome you to Strategies for Improving Blood Pressure Control. Before we get started today, I do have a few housekeeping items. First, today's session will be recorded. The recording will be emailed to you and will also be available on VHQC's website within 7 days. Also, we want to learn from each other, so today's session will be interactive. We ask you to please participate when questions are asked, either through the polling feature or the chat box. You may also use the chat function to send our presenters a question. Camille Coy will be monitoring the chat box. We may not be able to address your question during the session. However, any question we are unable to answer during the presentation, we will follow up with you after the webinar. You may access the chat by clicking the chat icon in the upper right-hand corner of your screen. Finally, we would greatly appreciate your feedback to assist us with future planning. Please take a minute to answer the questions that will appear on the right-hand side of your screen after the presentation. VHQC is a private, not-for-profit healthcare consulting company and has served as the Quality Improvement Organization, or QIO, for the state of Virginia since 1984. We are excited about the opportunity to now serve as the Quality Innovation Network Quality Improvement Organization, or QIN-QIO, for Maryland and Virginia. As a QIN-QIO, we convene providers, practitioners, stakeholders, and beneficiaries to build and share knowledge, spread best practices, and achieve improvements in patient care and health outcomes. The VHQC consultants come from a wide range of healthcare backgrounds. Our experienced team includes former hospital executives, a nursing home administrator, physician practice managers, nurses, health information managers, health communicators, physicians, and pharmacists. Building on our QIO experience in electronic health record adoption, data reporting, and care coordination, we also serve as Virginia's statewide Regional Health Information Technology Extension Center, also known as VHIT. As you can see, we've got a pretty full agenda to cover over the next hour. We're going to look at things from a patient's perspective and see how hypertension measures up. You'll learn about a map to achieve optimal hypertension control from our guests from the American Medical Association and see what participation in our Heart Healthy, the Cardiac Improvement Network, has to offer you. We'll wrap up with some question and answers, time permitting. One of our focus areas in this initiative is on improving the lives of patients and having them take an active role in the management of their hypertension. In that light, we want to start today's webinar with Ron Thompson's story. He couldn't be here today, but Camille Coy, one of our improvement consultants, is going to share a story with you.
Good afternoon, everyone. I met Mr. Thompson about a year and a half ago when we were doing some work in his area. And he is truly, if you meet him, he is truly the picture of health. He leads walking and running groups in his community. He has an organic garden in his backyard. He's always promoting health and wellness with whomever he meets. And he runs several races a year, varying distances, from like 5Ks to half marathons, which are 13.1 miles. But that was a very different picture about 6 or 7 years ago when he retired to Virginia with his wife to be closer to family. When he moved to Virginia, he suffered from high blood pressure, failing health, and he couldn't even walk around the block. And so he worked with his provider to change his, what he called his New York lifestyle around, where before he was eating a lot of greasy foods and fast foods and things like that, to just changing his eating habits and adjusting his physical activity to improve his health. So over the course of a few years, he went from being able to walk maybe 15 minutes 3 to 4 times a day to running 30 minutes 3 or 4 times a day. And now he's, like I said, running about maybe 30 to 40 miles a week, which greatly improved his health. He lowered his blood pressure, his eyesight stabilized. Again, working with his physician, he was able to get off of his high blood pressure medications and to really be an advocate for health and wellness in his community. Mr. Thompson, although retired, works at a free clinic where he talks a lot about health and wellness with community members and how they too can work with their providers to turn their lifestyles around, to eat better, to make those lifestyle adjustments that are needed to see improvements in health. And so he's just a really great story that I like to share when we look at things like how do we help Medicare beneficiaries get to the point where they are participating actively in the improvement of their health. And I will say that Mr. Thompson is 66 years old this year, and he's doing very, very well and is a true advocate for not only improving his health, but his family's health and the health of his community. So.
Thank you, Camille. Mr. Thompson's story is the kind of story we like to hear. We can, however, also learn from stories that might not be so successful, or at least not yet. If you have Medicare patients who are willing to share their stories, please let us know. As you can see from this slide, hypertension is alarmingly prevalent. It occurs in 67 million American adults, or 1 in 3 people. But where do Virginia and Maryland stand? According to the Virginia Department of Health's Hypertension Burden Report, Virginia is at about the median level compared with the entire U.S. in prevalence. In 2010, it was estimated that 31.2% of Virginians reported that they had been diagnosed with hypertension. 32% of Marylanders report having been told by a health professional that they have high blood pressure, according to the Maryland Million Heart Hypertension Fact Sheet. High blood pressure is a major risk factor for heart disease and stroke, which are the first and fourth leading causes of death for all Americans. While this problem affects all Americans, research shows that racial and ethnic populations are at a far greater risk. As a result, the primary focus of our initiative is on racial and ethnic minorities, people in rural areas, and the physicians who serve them. Because high blood pressure lies at the center of heart disease, blood pressure measurement and control are essential to preventing cardiovascular disease and decreasing the associated high mortality rates in the nation. It is estimated that nearly 36 million adults have uncontrolled blood pressure, which is considered to be a reading greater than 140/90. This group can further be divided into 2 subgroups. The first is those who are unaware of their hypertension. Interestingly, these people are under a physician's care with elevated blood pressure documented, but hypertension is neither diagnosed nor treated. This is referred to as hiding in plain sight. The second group are those who know they have hypertension and are taking medication for it, but do not yet have it under control. Of note is the fact that of the 36 million whose blood pressure is uncontrolled, 32 million of those have a usual source of care, and 30 million are insured, including 14 million Medicare beneficiaries. The most compelling statistic, however, is that nearly 3 of 4 with uncontrolled hypertension visited a healthcare professional at least twice in the prior year. Opportunities are being missed to initiate and improve the care of patients with hypertension, and as a result they are experiencing preventable myocardial infarctions, strokes, and kidney and heart failure. The information I just shared came from an article published online in the Journal of the American Medical Association entitled Protocol-Based Treatment of Hypertension, a Critical Step on the Pathway to Progress. If you would, take a minute and think to yourself about this question as it relates to your practice. Do you know what percentage of your patients are controlled? Are you confident that you've captured all of your patients that have hypertension? In 2010, direct medical billing to treat hypertension totaled $42.9 billion, with almost half in the form of prescription medications. Average annual expenditures were $733 per adult, which is the yellow line you see in the graph. Earlier I mentioned the disparity in racial and ethnic populations, and here you can see the same disparity in cost for care. I found this graph in the report, An Unhealthy America, Economic Burden of Chronic Disease by the Milken Institute, which is a nonprofit, nonpartisan think tank whose mission is to improve the lives and economic conditions of people in the U.S. and the world. According to the Milken Institute, on our current path, we will experience a dramatic increase in chronic disease in the next 20 years. But there is an alternative path. This graph illustrates the number of cases that can be avoided by making reasonable improvements in preventing and managing chronic disease, and in this case, hypertension. I'd now like to introduce our guest speaker, who will tell you about a program that we're really excited about. Vikas Bala is an improvement advisor for improving health outcomes at the American Medical Association. In this capacity, he drives quality by providing technical assistance, sharing best practices, and analyzing data respective to the Improving Health Outcomes Blood Pressure Initiative for the QIN-QIOs. Prior to joining the American Medical Association, Mr. Bala served as the program manager for the American Hospital Association, Health Research and Educational Trust Hospital Engagement Network, leading quality improvement initiatives aimed at reducing hospital-acquired infections and readmissions. He also worked for the Joint Commission, managing the standards development research needs for the laboratory and certification programs and risk management and performance improvement tools for surveyors and accredited healthcare organizations. Mr. Bala received his undergraduate degree from the University of Illinois at Chicago in psychology and his Master of Public Health and Master of Business Administration from Benedictine University. Welcome, Vikas. I'll go ahead and turn it over to you.
Hello and good afternoon, everyone. Tim, thank you for the wonderful introduction. My AMA and Johns Hopkins colleagues and I appreciate the opportunity to join you all on the webinar today, and we are very excited to share with you all a little bit more about our Improving Health Outcomes blood pressure program. So with that, I will go ahead and get started. Again, I'm Vikas Bala. I serve as an improvement advisor for the Improving Health Outcomes team here at the American Medical Association. I'm joined today by several of my colleagues who I will very quickly introduce and then jump right into our content. On the line from the AMA, we have Dr. Donna Daniel, Director of Health Outcome Strategies and the co-lead on the Improving Health Outcomes blood pressure program. Also Dr. Greg Wozniak, Director of Outcomes Analytics, Dr. Michael Rakos, Director of Chronic Disease Management, and Linda Murakami, Improvement Advisor for Health Outcomes Strategies, and also we have Robin Telford, Data Analyst for Outcomes Analytics. And then joining us from the Johns Hopkins end, we have Dr. Lisa Lebomsky, Assistant Professor with the Armstrong Institute for Patient Safety and Quality, and the co-lead on the Improving Health Outcomes Blood Pressure Program. And today I will be discussing our work on a map to achieve optimal hypertension control. So if we could please turn to the next slide. Great. So I wanted to share today why the AMA is focusing on improving health outcomes, describe some of our work on a QI framework and program on blood pressure control, and then last to share some of our progress with our current practice sites. And when I say practice sites, I'm referring to those practices that we recruited to help guide, create, and test our program, which I will further expand on later in the presentation. Next slide, please. So here you'll see the three areas of focus under the new AMA strategic plan. The first, improving health outcomes, which is where the blood pressure program exists. Second is the physician satisfaction and practice sustainability with payment models. And lastly, accelerating change in medical education. So as you've heard earlier, hypertension is alarmingly prevalent and is an obvious issue across the nation. And as Kim shared some really distressing statistics which answer the why we need to focus on hypertension question. And so I won't spend any extra time elaborating on this component, and I'll venture to guess most on the line may already know this. So with this information on hand, the AMA picked cardiovascular disease, specifically hypertension, along with prediabetes as the areas of focus for the Improving Health Outcomes strategic imperatives. Next slide, please. So I'll share here a little bit about our approach to achieving optimal blood pressure control rates. We know that we needed to engage with medical practices and health centers if we wanted to excel and actually do this work. And so we reached out to these very experts in the field to participate in and guide our work. As such, we also partnered with, as you heard earlier, Johns Hopkins Medicine, Dr. Peter Pronovost and his Hopkins team developed the CUSP, the Comprehensive Unit-Based Safety Program model, which some of you may already be familiar with, that was used in the ICU and inpatient setting, predominantly around crash and VAP reduction. And so we're working with this team to adapt this model for the ambulatory care arena and to determine how it best applies to chronic conditions like hypertension. So we also wanted to identify existing tools and resources that were already out there. And so we're collaborating with the Million Hearts team at CMS and CDS to really identify what these are. We're also working with a group of medical practices and health centers, which I will share more about coming up. And this group is really helping us decide which are the most relevant and effective resources. And when we do identify gaps, we've been able to develop tools and resources to really fill this void. So I'll share more about that on the next slide. We also realized early on that for primary care, both office practices and health centers, they're often not positioned well to be able to measure and report on blood pressure control rates. And so we're thankful for organizations like VHQC who support the practices and working with the EHRs and being able to extract actionable items from this data. And then really our overall approach also included identifying relevant advocacy opportunities. So one of the things we've been talking with Million Hearts about is how do we ensure that those that need self-monitoring blood pressure devices can get coverage, for example, Medicare beneficiaries, and really to determine the feedback loops to the physician and the care team. Next slide, please. So in addition to partnering with Dr. Peter Pronovost and his team at the Armstrong Institute for Patient Safety and Quality, we also partnered with Dr. Lisa Cooper at the Center to Eliminate Cardiovascular Health Disparities, and we incorporated much of her work in reducing health disparities for the primary care setting. We also have recently added a patient and family advisory panel, which again I will speak more about shortly, but this group really helps to ensure that the tools and resources that we're promoting are in fact patient-centered. So as you'll notice on these map screenshots, that we've identified 5 sites in Illinois and 5 sites in Maryland, and we've partnered with each of these sites to, each of these practices to prototype for the last year a program that would achieve optimal hypertension control rates. We began with these sites in Q4 of 2013. All very diverse practices. We have a solo practitioner, a federally qualified health center, a multi-specialty practice with 14 physicians that also has a residency program, among others as well. So these 10 sites all also have 6 different EHRs, and all vary with respect to the patient populations that they serve. Next slide, please. So this is the framework that we are promoting as part of the Improving Health Outcomes Blood Pressure Program. We refer to it as the MA.P framework for achieving optimal blood pressure control. As you can see on the slide, M stands for Measure Blood Pressure Accurately. A stands for Act Rapidly. This is really where we're asking physicians to take a look at how they're working to use the data to identify the list of patients in their practice attributed to them, and ensure that they are bringing them back if they are uncontrolled within a 2 to 4 week window until they achieve control. Here we also like to point out that bringing the patient back does not necessarily imply an office visit, but can be varying methods of touch points. Also, we are heavily promoting the Million Hearts work around standard protocols. And then the P stands for Partner with Patients, Families, and Communities to promote self-management. So essentially, how do practices do the best job they can in engaging patients who have a chronic condition and are making decisions to take medicine or lifestyle changes and really to engage them. So the foundation that really supports this framework is getting actionable data in the hands of physicians so that they realize there is an opportunity to make improvement, to determine what are the tools and resources necessary to support teams as they make these changes. And lastly, how do we promote a change in culture and embrace teamwork and open communication? So like many QI efforts, we know that having data and information that is actionable and recent is very critical. And so we're also currently working on a second iteration of a program guide, which consists of relevant tools and resources based off of our learnings with the 10 practice sites. Next slide, please. So each of these change concepts, measure accurately, act rapidly, and partner with patients, families, and communities, comes with a checklist. We believe, based off of our review of the evidence and the review of our national expert panel, there are some overarching key steps that need to occur for each component of MA.P. So what you see in front of you is actually hot off the press and our most recent version of the MA.P. framework checklist. On the leftmost column, you see measure accurately, which reflects what sites must do when they're screening patients. Then you'll also see the checklist for act rapidly and partnering. And at the bottom of each, you'll see some tips that probe a bit further into some specific information. And we do recognize that these checklists are a starting point, and these, along with several of our tools and resources, can be adapted to meet the needs of the local environment. So, in addition, as we continuously monitor new evidence in the field, we maintain and update these checklists to provide the most up-to-date and evidence-based information. Next slide, please. So we also, as part of this program, have a curriculum for the 10 practice sites that we work with. In addition to the checklist, we have an assessment tool that helps identify the context of the practice environment. We also have an assessment tool for understanding how a practice is implementing the MA.P. framework. We have a variety of tools that practices can pick and choose from as it relates to what would work best for their specific local needs. Our work with these sites also includes a webinar series. This series has pre-recorded didactic pieces that physicians and their care teams can listen to on their own availability, and then we bring this group together to have some dialogue and some peer-to-peer learnings that we term Share Your Experience webinars. So, in addition, we also have practice facilitators who go on site and work with these 10 sites in their QI efforts and implementation of these tools and resources. So next slide, please. So as I briefly brought up earlier, here you'll see a picture of a wonderful patient and family advisory panel. Again, the panel is a relatively recent addition to our work as of August 2014, so not too long ago. Next slide, please. So here you'll see the great impact this panel has on the work that we do. We asked this panel to review or help create educational or informational materials. These advisors often help create materials like forms or handouts and help us make these materials easier for all patients and family members to understand and use, and to really discuss what would be offered in the community that would help support patient self-management. We also asked the panel to suggest which products and programs should be prioritized because of their potential usefulness to patients and families, and also to work on some short-term projects, some of which we asked advisors to help us in making improvements for example, helping to plan and design a self-management plan for patients diagnosed with high blood pressure. And then lastly, sharing your story. We think that's a critical component in the work of a patient and family advisor. Advisors really help by talking about their healthcare experiences with the clinicians, staff, and other patients and groups, as Ron so kindly allowed his story to be shared earlier on in the slides. Next slide, please. So again, reiterating what I mentioned before on our work with the Center to Eliminate Cardiovascular Health Disparities and incorporating the work of Dr. Lisa Cooper and her team, but also the AMA is collaboratively working with the National Medical Association and the National Hispanic Medical Association to run the Commission to End Healthcare Disparities. So this year's focus for the Commission is on ensuring that there is good data collection around race, ethnicity, and language. Next slide, please. So here I want to briefly tell you a story of one of our physicians that partnered with us on the development of the Improving Health Outcomes Blood Pressure Program, and that is Dr. Mitch Gittleman. He is a private practice physician in Salisbury, Maryland on the Lower Shore, and he has 2 physician assistants he works with along with some other staff, but overall a small to medium-sized practice. So Dr. Gittleman was able to really engage around the data that we were able to put in front of him, as you'll see on the next slide. So if we could just turn to the next. Okay, so Dr. Gittleman did a drill down on addressing disparities in care, where he looked at the number of patients he had in his practice that had uncontrolled hypertension and are African American. And this number was 35 out of 133, as you see on the screen here. So he identified that there were 19 male, and knowing that one of the largest groups with the greatest disparities in hypertension are males aged 45 to 60, he did a chart review on these 19 cases using his EHR. For purposes of this presentation and to stay within the time limit, I will share here with you the breakdown of the 19 male African American patients with uncontrolled hypertension. However, I did want to point out that having been able to filter his data on this group, Dr. Gittleman is able to continue his analysis on female patients as well as other drill downs to obtain some actionable data on. So again, going back to the 19 patients here, he identified that 2 patients of the 19 were no longer in his practice. So a lot of times we understand that data isn't always perfect and clean, so he was able to make some modifications to indicate that these patients should not be attributed to his practice. He also found that of the 17 remaining patients, 5 had achieved control because he was acting rapidly to make this happen, which was a real win for him. And then 7 remained uncontrolled but had come in to see him, to which he thought was some good progress as well as it directly tied to the level of management these patients were receiving. But he also identified that there were 4 patients that, although had a follow-up appointment, did not actually come in. So during this time, we actually saw a shift in Dr. Gittleman's perspective, where instead of writing patients off or possibly saying that these patients were non-compliant, he instead felt that there was more that he could do. And so we worked with his MAs to reach out and determine why these patients missed their appointments and work to actually get them to come in. He also identified that one of his patients were being managed by a cardiologist, but he had not received any update from the cardiologist in quite a while, which really prompted him to reach out and inquire. So Dr. Gittleman has a very high control rate, hovering around the 83 to 85% range. When he started with us at the start of the prototyping phase, he was in the 70% range, so he's thrilled to see the increase and to really be able to look at his data in a different light. Next slide, please. So here you'll see the results of a site experience survey that we administered to our 10 practices to assess elements of the overall collaboration with the Improving Health Outcomes Blood Pressure Program. This slide reflects 2 particular questions that were asked: the overall satisfaction with the program, and would you recommend to other practices? So as you can see on the screen, I apologize if the text is a bit small, but the responses are pretty strong, with 75% respondents were satisfied or very satisfied for their overall satisfaction, and then 91% said that they would recommend to other practices. Next slide, please. And here you'll see the results from the same survey, but the question assessed the practice site application of the MA.P. tools within each site. So here the results are based on the number of survey respondents, showing 94%, 84%, and 71% of respondents felt that the measure accurately, act rapidly, and partner with patients, families, and communities tools could be applied and utilized in their practices respectively. Next slide, please. So again, this is the same site experience survey results, this time asking the respondents to describe their level of agreement that participation in the Improving Health Outcomes Blood Pressure Initiative helped the practices in the components listed. And these elements, as you can see, are highlighted in the x-axis. The y-axis. Overall, you can see strong agreement that these elements within the blood pressure program was helpful to these practice sites. Next slide, please. So here you will see the weighted average of 8 of our participating practice sites. The weighted baseline average is the average of the control rates from September, October, and November, which you can see marked on the x-axis. It provides a more reliable estimate of the baseline control rate. So the weighted baseline average was used to assign sites to either the high, medium, or low group. And the low group consists of data from 2 sites. The middle and high groups consist of data from 3 sites each. And as I mentioned earlier, this prototyping phase kicked off in December of 2013. So I'd like to emphasize here that really the main purpose of the prototyping phase, since Q4 2013, was really to partner with sites to develop a program, and therefore sites were helping us create and build the tools and resources while simultaneously testing it. And I think essentially, it was building the plane while flying it as well. So our prototyping work was less about improving blood pressure control rates as much as it was to really understand the fundamental needs and create the appropriate tools and resources to support improvement in control rate efforts. So here you see practice level data, which includes data from some physician care teams that actually did not participate, and also the level of participation from the care teams that did participate varied as well. The flat lines in the top two tiers, so I'm referring to right now the blue and gray lines, are greater than the national average, and then the lower tiers, so the purple line, visually displays upward movement, although that is not statistically significant. So moving forward, we will need to assess based on the level of participation in education intervention, and we'll continue to track performance and continue to measure and evaluate the program overall as well. Next slide, please. So we've identified some next steps from the AMA Johns Hopkins end, including, as I mentioned earlier, a revised version based off of our learnings from our practice sites on the Improving Health Outcomes Program Guide. We're also in the process of organizing a national webinar on blood pressure program next month. And we're working on a curriculum for the QI and QIO community to be rolled out later this year. And then also to continue collaborating and continuing discussions with VHQC and CMS on blood pressure control efforts both in Virginia, Maryland, but also across the nation. So if you could please turn to the next slide. I wanted to just briefly take a minute here to thank our 10 practice sites for their continued efforts and support of the Improving Health Outcomes Blood Pressure Program. We pulled many learnings from each of these sites and would really like to acknowledge their efforts. Next slide, please. So I will go ahead and end there. I again would like to thank VHQC and those who have joined the webinar today for giving us the opportunity to share a little bit about our program here at the AMA in partnership with Johns Hopkins. Here I've listed our contact information. Please feel free to reach out to any one of us if you think of any questions. I know I shared a lot of information, so if you think of anything after this webinar, please feel free to reach out to any of us. And so I think at this time, unless Kim says otherwise, I think we have some time for a brief Q&A. So Ryan, if you could go ahead and open up the lines.
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 on your telephone keypad. Questions will be taken in the order they were received. If at any point your question has been answered, you may press 7 again to disable your request. Please hold while we wait for the first question. And if you do have a question, please press 7 on your telephone keypad.
Okay, we can go on. If you do come up with a question later, please remember you can type it in the chat box, and we'll either address it at that time, or if we run out of time, we will get that to you. And thank you, Vikas, for joining us today.
Thank you.
All right, now we'll take a look at the opportunities that VHQC's Cardiac Improvement Network has to offer. In an effort to make improvements in preventing and managing hypertension, VHQC, along with many other organizations, has aligned our initiative with Million Hearts. This initiative rallies communities, healthcare professionals, health systems, nonprofit organizations, federal agencies, and private sector organizations around a common goal, that of preventing 1 million heart attacks and strokes by 2017. So now we have a quick polling question for the audience, and you will see the question pop up on the right-hand side of your screen. Emily, would you please display the polling question? How many of you have signed up to partner with Million Hearts? Please take a moment to go to the right side of your screen and select an answer, and we'll see the results momentarily. We'll give it just a few more moments, and while we're waiting, partners support Million Hearts through a wide range of activities, so see what you can do to become involved. We all have a role to play in achieving the Million Hearts goal. Okay, looks like we've got our answer. It looks like the majority of you have heard of Million Hearts, and you are a Million Hearts partner, so that's great. For those of you that haven't heard of Million Hearts before, I do have the website there at the bottom of the screen. Take a moment to go to the website, and you can learn how to become a partner, and it's just filled with a plethora of information in regards to the program and hypertension management. Thank you for participating in the polling question. Million Hearts focuses on 4 changes that we can make in our communities and healthcare systems that support long-term reductions in heart attacks and strokes, and these are referred to as the ABCs, those being aspirin as appropriate, blood pressure control, cholesterol management, and smoking cessation. Professionals can harness the power of health information technology and utilize new models of care that educate patients about their conditions and the ABCs of heart health. Health information technology, electronic health records, and health data are vital to identifying which treatments are most effective. Payers are increasingly keeping track of chronic disease care data to evaluate physicians and hospitals, incorporating those metrics into payment reforms and policy changes. CMS, for example, has a dashboard tool to help researchers, physicians, and policymakers gather information about how to increase the quality and reduce the cost of care. And you'll hear a little more about electronic health records and health data momentarily. By participating in Heart Healthy, the Cardiac Improvement Network, you will get the support you need to reduce cardiac disparities within populations that are disproportionately affected by heart disease, increase use of the evidence-based ABCs approach to reduce cardiac risk, and become familiar with and use the resources of the Million Hearts Initiative. Additionally, you'll have access to tools and resources based on scientific evidence and the best clinical and communications practices from local, regional, and national partners. You'll receive expert guidance on helping patients engage in cardiac disease self-management practices, and you'll have access to colleagues who have surmounted the challenges that you face, including high-performing Maryland and Virginia providers in both urban and rural settings. Previously, you heard me mention that payers are increasingly using electronic health records to keep track of chronic disease data to evaluate physicians and hospitals. They're then incorporating those metrics into payment reforms and policy changes. Another program offered at VHQC, which is closely aligned with our Cardiac Improvement Network, is the Quality Reporting and Incentive Programs Network. As a participant in the Cardiac Improvement Network, you will receive the added benefits of dual participation in the Quality Reporting and Incentive Programs Network. With a goal to improve performance on measures included in the CMS Value-Based and Quality Reporting Programs, this network will provide you with access to educational materials and events that will help you better understand the goals and requirements of the multiple CMS physician incentive and quality reporting programs, access to tools such as fact sheets and pocket cards that focus on program measure improvement, and access to improvement consultants who will respond to your individual questions and assist you with analyzing your quality reporting data to identify gaps in quality of care and developing interventions to address the identified gap in quality of care. These programs are available at no cost to you and will be invaluable to your practice. A participation agreement was included in the webinar materials that you received. All you have to do is complete it and return it to get started. And we have a save the date for you. There is a webinar coming up on February 5th, 2015 at 12 noon, and it's 2014 PQRS submission for eligible professionals. You should have seen an invite for this, but I just wanted to remind you about it. During the webinar, we will review the requirements for PQRS 2014 submission and any Medicare penalties for non-participation. If you haven't received an invite, please let us know and we can get one to you. Also, as I think Vikas mentioned, the American Medical Association will be presenting a webinar in February for American Heart Month. That date is yet to be announced, but we'll definitely keep you posted. On this slide, you'll find our contact information. Please don't hesitate to contact us with any questions you may have. And we have a few minutes for questions, but first the operator will post the evaluation before opening up the lines. Ryan, would you please post the evaluation and then open up the lines for questions?
Certainly, the floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 on your telephone keypad. Please hold while we wait for the first question.
And while we're waiting for any questions, if any of you, Vikas, over at AMA, have anything you want to add or any additional information, please feel free to share at this time as well.
Hi, Kim. Sorry, actually, I don't think we have much to add. I just wanted to thank you all again for inviting us, and you have our contact information, so please feel free to reach out to any of us if you think of any questions later.
Okay. All right, and then if you can open the chat back up and make sure everybody questions.
No questions in the chat.
Okay. All right, well, if there are
no questions on the line at this time.
Okay, thank you. If there aren't any further questions, again, don't forget to answer the evaluation. And we just want to thank each of you for participating in today's webinar. And a special thank you to Vikas Bala and his associates there at the American Medical Association for presenting. Again, please take a moment to complete the evaluation questions before leaving. And thank you, and have a great afternoon.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your line at this time.